Hello everyone and welcome to set 19 of the part 1 questions. Let's get going. First question here, you're performing a well child examination on a 4-year-old girl. The patient was recently adopted after being removed from the biological mother for abandonment. What changes might you see in your evaluation? And then what are the effects seen in an infant when there is long-term deprivation of affection? So overall here we're looking for signs of poor care, neglect, even depression. Now physically there may be evidence of malnutrition, which could manifest as short stature or weight that's low for her age. You might also look for dental caries, skin infections like scabies. Those would be more common in a neglected child who hasn't had good hygiene, obviously. Now the next part of this, what are the effects seen in an infant when there is long-term deprivation of affection? So the question, the first part of the question was for a 4-year-old, but now we're talking about an infant. And infants that are deprived of affection might show evidence of poor muscle tone. Later on, they might have difficulty with language skills, poor socialization skills later on. You're going to see lack of eye contact, weight loss, and a big one, failure to thrive. Next question. A person eating fugu sashimi in Japan is at risk of what toxicity? And what is the mechanism of this toxicity? So fugu is a Japanese word that means river pig, and that's what they call pufferfish, fugu. Now if pufferfish is not prepared correctly, the person eating the fish can ingest a lethal dose of tetrodotoxin. So this is a neurotoxin that binds to voltage-gated sodium channels, and that's going to prevent depolarization. Now this can cause things like coma, respiratory arrest, and even cardiovascular collapse, anywhere from about 17 minutes to 4 hours after ingestion. So it could be very, very dangerous. Next question. A 25-year-old woman presents to the clinic with severe pelvic pain that is always associated with menses. What diagnosis is characteristic of this type of pain and often results in infertility? What is the classic finding on the ovary that is associated with this diagnosis? So this is endometriosis, where you have endometrial tissue outside of the uterus, so maybe on the ovaries or on the tubes or out on the intestines even. And this endometrial tissue does what it's basically supposed to do. It goes through a cyclical proliferation and shedding with the menstrual cycle, and this is in response to estrogen and progesterone. But all that bleeding in unusual locations can be very irritating to the surrounding tissues, and that's what's going to cause that cyclical pain. Now, what is the classic finding on the ovary that is associated with this diagnosis? Well, endometriosis can have multiple presentations, but on the ovaries, you might see something like a blood-filled, sometimes we refer to this as a chocolate cyst, kind of gross, on the ovaries, or possibly on the peritoneum as well. Next question. Which antifungal drugs cause gynecomastia and by what mechanism? And then what diuretic drug causes gynecomastia and by what mechanism? Well, first one here, what are the antifungal drugs? Well, the antifungal drug that causes gynecomastia is ketoconazole. Ketoconazole inhibits the first step of steroid hormone synthesis. So that first step is the conversion of cholesterol to pregnenolone by the enzyme desmolase. So ketoconazole inhibits desmolase, and you get reduced testosterone production, and that leads to gynecomastia. Ketoconazole also happens to be a weak androgen receptor antagonist, but that's definitely a secondary mechanism. Now, what diuretic drug causes gynecomastia? Well, the diuretic is spironolactone, which is an aldosterone antagonist and a potassium-sparing diuretic. It causes gynecomastia by increasing the conversion of testosterone to estradiol, and it also blocks testosterone synthesis. And it has some action as an antagonist of androgen receptors as well. Now, real quickly, there's a PG-13 rated mnemonic for the drugs that cause gynecomastia, and this one is some drugs cause awesome knockers, which stands for spironolactone, digitalis or digoxin, cimetidine, alcohol, and ketoconazole. All right, next question. How many half-lives does it take for a drug infused at a constant rate to reach 94% of steady state? What variables determine the half-life of a drug? So it takes 4 to 5 half-lives for a drug to reach steady state. The percentage of drug at present after 2 half-lives is 75%. After 3, it's 87.5%. And at 4 half-lives, it's 93.75%. So these are useful numbers to have in the back of your mind for the test. Now, what determines the half-life of a drug? Well, it's going to be volume of distribution and clearance. So the half-life is going to equal to 0.7 times the volume of distribution, and all that is going to be divided by the clearance. All right, next question here. What are the early cyanotic heart diseases? What are the late cyanotic heart diseases? So first one here, what are the early cyanotic heart diseases? So these are pretty easy because they all start with T, so we call them the 5 T's. And last year a student from GW sent us a great mnemonic which helps you to remember these in numerical order, and this is just using your fingers. So 1 is a persistent truncus arteriosus because it is one big vessel. 2 is kind of like a cross, is transposition of the great vessels because there are 2 inverted vessels, they're kind of crossing over each other. 3 is a tricuspid atresia, so 3 for tri in the tricuspid, that's pretty easy. 4, tetralogy of Fallot, that one's pretty easy because of the tetra meaning 4. And then 5 is total anomalous pulmonary venous return because the name total anomalous pulmonary venous return has 1, 2, 3, 4, 5 words, and that's kind of pushing it. It's also total, so it has to be the largest number. So those are the big 5 T's: truncus arteriosus, transposition of the great vessels, tricuspid atresia, tetralogy of Fallot, and the total anomalous pulmonary artery venous return. And then what are the late cyanotic heart diseases? So it's atrial septal defect, ASD, a ventricular septal defect, VSD, and a patent ductus arteriosus, a PDA. All right, next question. What is the mechanism of action of penicillin? Is it a bacteriostatic or a bactericidal antibiotic? So penicillin blocks the synthesis of bacterial cell walls because it inhibits the cross-linking of the peptidoglycans that make the cell wall. Now you need to know how the different antibiotics works. That's very, very high yield stuff. Now, is it a bacteriostatic or a bactericidal antibiotic? So bacteria are constantly remodeling their cell walls in order to grow. So they have enzymes called autolysins that break down a piece of the cell wall. But when the penicillin is on board, those bacteria can't make those new cell walls. So they become susceptible to osmotic damage and they swell up and burst. So penicillin are bactericidal. Next question. Describe the anatomical layers of the penis. So we have the outer dermis, we have the dartos muscle layer, we have the deep fascia or Buck's fascia, we have 3 cylindrical masses of cavernous erectile tissue encased and separated by the tunica albuginea. We have 2 dorsolateral corpora cavernosa, we have 1 ventral corpus spongiosum, and then we have the urethra. Next question. A 37-year-old patient with refractory peptic ulcer disease undergoes an EGD. Biopsies of the duodenum reveal hypertrophied submucosal glands. What are these glands? And then next we have what are Peyer's patches? How can these structures help you identify the location from which a histological specimen was taken? So this is a classic presentation of a patient with chronic severe peptic ulcer disease or PUD. These hypertrophied submucosal glands are called Brunner's glands, and these are found in the duodenum and secrete alkaline mucus to neutralize stomach acids. Hypertrophy of these glands indicates an excessive amount of acid production, as might be seen in a peptic ulcer disease patient. Now, what are Peyer's patches? Now, these Peyer's patches are patches of lymphoid tissue in the ileum, specifically located in the lamina propria and submucosa of the ileum. Now, these structures are a very important part of the immune system known as MALT. And remember, MALT was mucosa-associated lymphoid tissue. Now, how can these structures help us identify the location from which a histological specimen was taken? So Brunner's glands are found in the duodenum. Peyer's patches are found in the ileum. We just went through that. All right, next question. What is the adult remnant of the following fetal structures? All right, so first we have the fetal structure, then we'll have the adult structure. So first we have the gubernaculum, and then we're going to have that lead to the ovarian ligament, plus the round ligament of the uterus, and obviously that's in a female. We have the processus vaginalis in a male, that's going to end up being the tunica vaginalis. We have the foramen ovale, that's going to become the fossa ovalis. And then we have the notochord, which will become the nucleus pulposus. All right, guys, that brings us to the end of set number 19. I hope you've learned something. I'll see you next time.